Hi, everyone. Welcome to XPC Talks. We're excited to have Bill with us today. He's a super cool person, ER physician, founder of Rocket Doctor, and he's passionate about telehealth and Medicaid, topics we're deeply interested in. So I'll hand this over to Bill to tell us a bit about himself, and then he'll pull up his slides and walk us through the work he's been up to, and we can have an interactive session.
Cool. Thanks, Paulius. And hi, everybody. Thanks for joining today. I don't know, I've met too many folks here, a couple of familiar faces, but yeah, like Paulius said, we've got a few slides to kind of help walk through some of the content for today. I might just open it up to give people a sense of what the proposed conversation is going to look like. And Google Slides has gotten good, so I can actually see anyone who's on video, or if you want to ask a question, feel free to raise your hand or otherwise, and or just jump in, unmute yourself and jump in with a question if you got one. Happy to do that. But yeah, this is the high level, what the plan is over the next 20 minutes or so. And then we'll just, as Polly said, I defer to you and we can jump into questions and kind of kick back and forth. But for the first bit, just kind of in terms of Rocket Doctor. So this is just, again, kind of like a placeholder to give some notes on the idea. But I usually talk about myself in the context of the company, and I'll give maybe a little bit of a longer version for folks here, just on how it all started. And so my background's in emergency medicine, board certified in family practice and EM. I'm Canadian. And so in Canada, you can kind of do this dual degree in family medicine and emergency medicine. And then when I was done residency, I went back to school to do an MPH at Hopkins, and then went down to the NIH to do a global cancer control fellowship at the Center for Global Health, the National Cancer Institute, and worked for a bit for Kaiser in South Baltimore, which will become relevant later on in the story around Rocket Doctor. And then went to USC, where I was teaching for a few years in LA, and kind of bouncing back and forth between Los Angeles, Toronto to do some ER work, East Coast, and East Africa. And the reason for that is because my first startup was actually about 13 years ago now in the nonprofit space, a group called Bridge to Health, Medical and Dental. And that actually kind of bleeds into the origin story of Rocket Doctor, which is with Bridge to Health. And this is a little more context than I might normally give, but of interest perhaps to the group is be in rural communities in East Africa, particularly in the southwest of the country, in a place called Kabale, which is on the border of DRC and Rwanda. And you're in these mountainous communities, and there'd be no doctors for anyone for miles around. And so, this is back in 2012, 13. This thought process was, God, if we could just get a doctor on a box that we could put out into these communities. And there was an idea around, could we mesh it with diagnostics and other tools? And so that led to doing a bunch of work with various things in the emergency department domestically. I was doing work on point of care ultrasound and started to put together initially an obstetrics program. And then from there launched into, bedside POCUS, and then into pediatric pneumonia, and became the first folks to bring the Butterfly IQ ultrasound, if people are familiar with that device. We were just about the first to bring it outside of the United States, just as they got FDA approval, and set up a cloud-based teleradiology program, training Ugandan physicians how to diagnose pediatric pneumonia in East Africa. And so that caught the attention through 6 years of gentle harassment of the science writer at the time at the New York Times. And he actually ended up coming with us into the field to Uganda and wrote a story that made its way to the cover of the science section back in 2019. And so that really kind of pushed me personally into the technology sector, because got a bunch of reach outs from folks. And actually an interesting Kenyan kind of B Corp company started by some guys from Wharton reached out and said, hey, will you come and, teach ultrasound? And that led to joining them as an interim chief medical officer, but they had a bunch of co-founder issues, and ended up parting ways with that company and kind of thinking, well, I think I'll just keep the nonprofit work for low and middle income countries with Bridge to Health, which still runs as a nonprofit, sends teams abroad and works with local government partners. And then we'll try to think about something domestically that we can do. And in that fall of 2019, it was a very busy flu season pre-pandemic, and lots of folks coming to the department. And was just thinking, God, if only we could keep people out of the hospital that don't need to be there with outpatient primary care services, particularly kids with cough, cold, flu, and other symptoms, and was thinking of integrating devices like Bluetooth stethoscope, digital otoscope. And so that led to the beginnings of the company. And it's actually interesting because we got an interview to Y Combinator at the time, and it was literally just the idea on a piece of paper. And, the questions were like, well, why would a patient do virtual care instead of in-person care? And, it was very, and I see Polly is smiling, but, the partner, we didn't get in, but the partner emailed me and was like, you seem smart. Seems like a cool idea. Airbnb started out as a mattress on some guy's floor. So go get some patients and reapply in the spring. And obviously, the spring hit, pandemic hit, and we just went to market as quickly as we could. And so it evolved from this idea of, a diagnostics kind of pediatric viral URTI company to suddenly, oh, this can actually be like an all-encompassing thing. And at the time, there were no publicly funded billing codes in the Canadian single payer provincial models, and those were created at the pandemic, and adoption went up. And so we just dove in head first, and away we went. So does that do it for the origin story, Paulius?
Oh yeah, that was great, and I love all because I guess we really met at JPM early this year, right? Like, so there's been a fast friendship, but I love that you add the color to it. I think this is definitely what makes it interesting.
Cool. And so, then on the kind of path to acquisition, so we formally incorporated the company in the spring of 2020, really dove in full time as of that point, and it was just a hell of a ride along the way. And I don't know, I mean, I'm more interested perhaps in what people have in the sense of questions on this, but it's I saw a really interesting and funny graphic of like, it goes up and you think, oh, this is really going to work. And then it goes down and you go, oh, next week we're going out of business. And then it goes up slightly higher. And it's like, oh, this is so wonderful. And then it goes down and it goes, I suck. I'm a failure. But the low point is just slightly higher than the last one. And then it goes up higher. Oh, wow, I'm the greatest. And then the next one even goes lower than the first time. And it's like, no, I was wrong. I suck. And then, eventually you get to an endpoint somewhere. And I think that's the path that, I've experienced over the last 5 years is you just sort of keep pushing and progressing, and something happens that throws a wrench in everything and you have to retool and pivot. Like, in 2022, government of Ontario cut funding to virtual care by 50%, and the markets fell out, and we had to rebuild our California business, and our tech wasn't good enough. We had to redo the, and then it changed from acquiring patients to being profitable to, while showing growth, and just a million things along the way. But this is why probably second time founders tend to do better also, with this idea that at the end of the day, to get acquired or to have an exit, from my perspective, and I've only done this once, and maybe people here have more experience than I do, but a company that is just makes sense. So it works for your users, and in our case, that's doctors and patients, and that number grows, and the business generates revenue, and ideally it doesn't burn a whole lot, and it's on the way to profitability. Like, those are the core kind of lessons to eventually get to acquisition, and then an alignment for the acquiring company as well on vision and mission. And so, yeah, currently from scale, we've done about 600,000 patient visits on the platform, have about 300 physicians with us across the US and Canada. And the way to kind of think about, and we'll talk about this a little bit further on, but the way to think about us is like a Shopify for physicians. So our model has always been different than the typical kind of virtual urgent care, virtual walk-in clinic. The goal has been physician autonomy and empowerment, and then a marketplace to connect doctors to patients, largely in rural or remote communities, or lack access to primary care on Medicaid, which we'll talk about also. And so the ambition, I have to be careful what I say now because we're a publicly traded company, so I can't say like too much future looking stuff. But in the acquisition, we have in the public press releases revenue targets to hit that basically looks like us doubling our revenue in the next 2 years or so. So yeah, as we kind of think about that point on access to care and what we're up to generally, we have our database where we always want to be able to pull information to understand what kind of patients we're seeing and where they're coming from, and are we achieving our objectives. And so a little while ago, we looked at the few thousand patients that we had seen in California to date. and we did a zip code analysis. And when we mapped back to 2015 to a commissioner's report of 135 underserved zip codes, we found we had already serviced patients in 106 of them. And so just making sure that we're actually reaching the folks that we're looking to reach. And so, we talked about some of this in terms of how we work. But, I think back to when I was working for Mid-Atlantic Permanente Group, which is basically Kaiser on the East Coast. And it was interesting because the chief there discovered quite quickly that I was a fast and efficient public ER doctor from the Canadian system, I guess. And so interestingly, I got put into kind of the urgent care zone where I had 2 nurses and I was seeing, I don't know, some ridiculous volume of patients per hour for like a 10-hour shift and getting this hourly rate that looked the same as my colleagues downstairs that were seeing much more complex, interesting cases. And I kept wondering to myself, like, I wonder what they're billing insurance for this work. And I wonder what I'm generating every hour for, revenue. And so I always had in the back of my mind, like, what if we could actually let doctors be independent? And I thought it was fascinating and ironic that in Canada, physicians are basically all independent, like for the most part, vast majority are independent contractors. We run our own businesses, we're sole proprietors or incorporated, versus I found in the US, we were always a part of practice groups or part of corporations. And so I thought, well, I wonder if we can bring that model back of allowing docs to be autonomous, but had to figure out all the complexities around medical malpractice insurance and payer enrollment and credentialing. And we'll talk a little bit about all of that. But we essentially helped to streamline and standardize that for docs. And then on the Medicaid side, when we started opening the business in the US market, we found that we were getting all of these requests for visits from patients on Medicaid, and went back to try to sort out what was going on and realized, well, many people didn't even have health insurance until the expansion of the Affordable Care Act on Medicaid. And then they couldn't do virtual care until the waivers by CMS at the start of the pandemic. And so, we were one of the few available where folks could come to and actually use their Medicaid, particularly in California, where we started to access healthcare services. So saw that as a big opportunity and really dove in head first. And then as you think about other sort of core components that we've done, one of the things we realized early on is that virtual care can be really crappy, and patients may just come in and then get sent to the emergency department or to a walk-in clinic. And so the idea was, well, we weren't trained in competency-based medical education on virtual care to a large extent. So every doctor is kind of differentially comfortable with different kinds of patients. And so we let doctors tell us how they want to see patients, and then we match them to the right group based on what you're confident managing in a virtual ecosystem. And then we have some stuff I'll talk about in a second around integration with those devices, going back to the very start of the company. And for Medicaid specific populations, of course, most people, not everyone speaks English, but most people don't speak English as a first language. And so we have live interpretation in hundreds of different languages. We've got, the website translated into Spanish for a project we have in New York we'll talk about. We've got it in Haitian Creole, Mandarin, and a variety of other things. And so on the device side,
Bill, can I actually ask a question around languages?
Yeah.
So as I'm beginning to talk to a lot more FQs and free clinics in the US this year, many of them see like multiple dozens of different kinds of languages per year. And it's one of the translation is a huge barrier. How did you go about sourcing that? Was it like a turnkey solution that you found a partner and they do everything, or was that an evolution?
Well, yeah. So I will just caveat the Canadian side of the business is further ahead than the US side. So where we've got 270 doctors on the Canadian side, we have 30 or so, maybe even 280 and 20 on the US side. And so on the Canadian side, where we're at scale, we keep track of languages that providers speak. And we have, I think, something like 22 to 30 different languages that docs speak. And then we can again match to the right patient based on their geographic region. We have many, different languages available also for the US docs, but we also additionally contracted with a single vendor that has live interpretation available in those hundreds of different languages so that we can plug them in. And we've built the ability for them to plug into our video visit sessions basically on demand when needed. Interestingly, we found a Canadian company that is quite cost effective that also can work in the US and Canada. I'm happy to share that with folks afterwards if they're interested. But does that answer your question?
Yeah, totally. Yeah, I definitely have follow-up questions, so we can talk later.
Cool. Yeah, and on the device side, we started the company with this idea of going direct to consumer for devices, like we were doing with virtual care, with the idea that we created these kits. So we had primary care, respiratory, ENT, and we would sell them to patients. And we tried multiple iterations of how we could do this in a subscription model. But ultimately, what we found is people didn't want to wait the day or two it would take to get the kit to have their virtual visit. And B, let's say we would do a respiratory thing, we'd send out the stethoscope, and the doc would go, "Well, your lungs sound fine." The patient would go, "Well, what did I just pay you for? Why do I need this thing if it's normal?" And so it's like, well, how do you communicate that a physician has to listen to like hundreds of lungs to hear the one that's abnormal? So that became complexity. And what we realized, that we didn't want to do like 3PL, all this other stuff. So we found interesting opportunities with B2B sales, particularly independently owned pharmacies, where they would have these spare rooms and they would want doctors but couldn't get access to them. So we would sell them the next best thing, which is one of these virtually enabled stations. And we plugged in Bluetooth stethoscope, digital otoscope, vitals. And we actually, as well, going also back to the East Africa days, published a research trial in 2024 on patient-directed lung ultrasound when paired in real-time teleguidance with a ER physician trained in ultrasound. So we're now thinking about, could we put ultrasound into these stations as well and try to avoid the requirement to go in for diagnostic imaging and that kind of stuff. So that's kind of the next level. And that's in about 20 pharmacies. Those are across Canada. And then in New York, we'll talk about, we have a deal with an IPA and 3 FQHCs and housing complexes. And so we've trained community health workers to take these devices on site in that partnership. And then on the screen right, we went through Google's AI accelerator in the spring of last year. And as a component of that, looked at a variety of different ways that we could try to integrate large language models, AI, into our tech stack. And over the last 5 years, we've built our own HIPAA compliant proprietary EMR with the goal, from the beginning for me, it was always like, how do we automate all the garbage that we have to do in clinical medicine that is so infuriating? And how do we let doctors just practice medicine? And this has become, over the last couple of years, buzzwords, and everyone seems to be saying it, which is great. But that was, we decided to build our own EMR from the very beginning because we didn't want to be reliant on a third-party software that could charge us whatever they want. And B, we wanted to have access to all the data and the UI and be able to just sort of build a new system as new tools came out. And so the first of those is Rocket Doctor Connect, which is basically automating a manual process that exists of manually matching to the right patient and appropriately deciding who is okay for virtual care versus who needs an emergency department visit in person. So that is moving into production actually in the next month or so, our MVP of that, which is great. Any questions on that stuff?
I think you're crushing it. You're a good storyteller, so keep going. People, I think, are tuned in. Yeah.
Cool. Thanks. Again, feel free to jump in if anyone wants to, and then in terms of more specifics on the Medicaid side, which I think some folks are interested in learning about, and everyone, as I think about over the years, like the last 5 years of doing Rocket Doctor, I've pitched something like 400 VCs to keep the company funded. So just think about all the various questions and sort of perceptions that people had about Medicaid patients, and try to present them kind of here, the realities and also some of the perceptions. But housing is an issue for some people. But that also brews, lack of trust in the system. And so in New York, I, by the way, am licensed in Ontario, Alberta, but also California, New York, and Maryland. So I'll see patients in all the territories on the platform. And it's interesting because the project in New York with folks in housing complexes, I've noticed the patients there have the least trust in the system, and they're typically in the Bronx and Manhattan. And often it's their housing worker that will force them basically and, cajole them into getting an appointment booked. And they kind of be like, I don't know why I'm here. And do I really need to do this? And so that's a core issue for sure. I think it's interesting that health literacy commonly was cited by VCs as a reason why people on Medicaid would not use healthcare. But I actually don't think that's correct. Like, people understand when they're sick and they get it that they need to see doctors. The issue is the other things that are below this. So, particularly transportation and work. So maybe you've got like 2 to 3 part-time jobs, but your doctor is only available on X day at X time, or it's an overstressed PCP that takes Medicaid, and you don't even know like who your PCP is, because California, for example, has a state requirement that you have to be auto-assigned a managed care plan within 90 days of getting onto state Medicaid. So somebody might get auto-assigned onto a managed care plan based on their geography. Every managed care plan has to then auto-assign you a PCP. So you get auto-assigned this doctor. You have no clue. The doctor doesn't know who you are. You don't know who the doctor is. You don't even know what a managed care plan is. But now you're trying to get healthcare, and you're like looking at some card you have, and you call some phone number, and a stressed out admin says, well, we don't have availability today. Go to the emergency department or a walk-in clinic, or we can book you for 2 weeks from now. So then I think that's much more what happens rather than health literacy. And you go, well, I got to go to work, and I've got my kids to take care of, and I got to find a bus schedule because I'm not paying. I can't afford an Uber to get to the doctor's office. So there's all those different factors that impact access to care. And I'll say, literally, I had a patient in California I saw just maybe a month or so ago who was on a bus when we started our telehealth call. And I was sort of, I don't know, I'm curious what other people would have done, but I said, I think it's probably not so private. You might want to just step off for a second. And so she stepped off and then got on the next bus as it came back. But the PCP side is quite sad. So actually, this same patient was I won't give too many details, but was in a healthcare profession and was unable to continue working full time. And so ended up losing their benefits. And we have an integration with a company where we can pull all past records from the patients and generate a problem list. And you can see all the PCP records and whatever else. There's a beautiful note from a provider just a month earlier. And patient was on like a dozen different medications, and they just stopped cold turkey because insurance kicked them off. PCP wouldn't see them, and they couldn't get their prescriptions refilled. So it's just a huge challenge generally. And then stigma. So yeah, providers often don't want to take Medicaid because of the perceived challenges of patients. But in many cases, for folks I've seen, they're just like working class Americans who need healthcare, and in often cases have fallen on bad luck for a short period of time. We try to do on the ground partnerships as well. And this is kind of stemming from the work with the nonprofit over the years, where we go into communities and we try to work with local groups, not particularly now, engaging with managed care plans. So we've been building a partnership with the Housing Authority for the city of LA for a number of years, and things, took a bit of a backseat with the fires, and it's been a little bit, it's government system, so it takes some time. But we did hold an event last year where we went on site and met some members in the community and had a little booth where we advertised and talked about healthcare services and health screening. And again, what was interesting was many people actually understood healthcare quite well. They weren't too surprised by it. And just going back on digital literacy, HACLA actually had a grant from a telecom company to get people high-speed Wi-Fi in the housing complexes and SIM cards and everything else, which I thought was pretty interesting. So any questions on any of the patient stuff? Cool. From the provider side, again, this is kind of going back to what I was talking about earlier. And I think what I sort of found, and I talked to a bunch of friends who are physicians as well, and I thought about it like I always put my doctor hat on, and I'm the first physician usually to try to do anything on the system just to test it out. And you just go, God, this is a lot of work. There's a lot of forms that we have to sign. And I think we often think to ourselves, well, I'm just a doctor. Like, I wasn't trained in the business of medicine. Like, I don't know. And I don't have time. Like, for example, I worked, 2 ER shifts over the weekend. And I'm pretty tired today. And I sort of think about, God, if I was full-time emergency med, and going back to that hat on, full-time clinical medicine, and now you're being asked to understand how medical malpractice insurance works and fill in all of these forms and paperwork, and what is my business going to look like in the future, and what revenue might I generate? And then you've got to figure out, like, okay, but if I see this patient, will I get paid for it? And who's going to do the billing for me? And what if I get in trouble or I do it incorrectly? And then I've got to, credential and give all this paperwork and my high school transcripts and do drug testing and all this other stuff. And so it's just like too complicated for many doctors. And so we try to simplify it and create a streamlined system. And then let's say you do all that, to then again take Medicaid becomes next to impossible, just simply because of government bureaucracy and all the complexities that you then have to do to then get credentialed and enrolled in Medicaid. So we try to basically simplify that for providers. And to do that, I wanted everyone to be independent totally, but we realized we had to produce a practice group. So we have a California medical group that's now in New York and Maryland as well. And docs just 1099 to the group. Basically, we give you a checklist. You just give us some information, you sign some forms, and then we help you kind of get through the process in that way. And there's a question from Shantanu. I hope I said your name correctly.
Yeah, you got it.
I got it. Cool.
And do you want to feel free to say the question out loud. That way, those that are not in front of the computer can also hear it.
Yeah. So thank you for sharing your experience. Just on the slide back, I was wondering other types of like differences between perception and reality. You talked about Medicaid population having a stigma, or like people thinking Medicaid population is one way versus the other. My perception is everyone has an iPhone somehow or another, right? So then people are on TikTok and Instagram. So there seems to be some tech adoption and use, but maybe not, depending on the elderly, or maybe tech not so tech savvy. So just curious what you thought of. Obviously, your solution is more tech forward, so people opt in for that. But just curious what you thought of when it came to the Medicaid population, when it came to tech usage.
Yeah, it's a great question. And it brings me back to these VC pitches, because I had so many questions. Do Medicaid people have phones? Do they access internet?
Right.
And so I actually added a slide in my deck that explained, out of the 13 million people on Medicaid in California, only 300,000 were experiencing homelessness. And basically like 99% of people were, again, just kind of like working class folks that, had fallen on hard times or whatever. And so the answer was yes, they have cell phones. And even people, who were unhoused would often have phones and some level of data also. So yes, certainly
Totally.
People have phones or on internet, but we don't want to understate that many people, including people who are not on Medicaid, find technology extremely difficult. And so even the simplest thing may be totally unusable by the average person. And so our application, we made a decision early on to make it a cloud-based system. So you don't have to download an app. And so that obviously makes retention a little bit different, but you just get an email or a text message, you click the link, you put in a 2FA code, and you get online as a patient. There's nothing else to do. So we've tried to make it as easy as possible for people to use the system, basically.
Can I have one more follow-up?
Yeah, go for it.
Just in terms of adoption. So one thing I've been playing around with is group chat or text messaging. I know maybe on the HIPAA side it's a little bit tricky, but just curious if you thought about that as part of your exploration of how to reduce tech cognitive load.
Yeah, we have some text-based messaging services. And when people sign on, they can do a visit, video, audio, or in the appointment by text, but we don't really advertise it, at least not on the Medicaid side of things. It's kind of a long story. We ended up doing it north of the border in Canada for a variety of reasons, but we haven't advertised it too much. We do try as much as possible to move to video visits, just because I think it does assist in sort of some of the clinical. But in some cases, text is better if it's highly stigmatizing, or people have a variety of different reasons for wanting to do text-based. But yeah, more to come on that, I guess, as we think about it more.
And Eric, you had a question about the scope of practice. Was there more to it than to what you wrote about virtual versus urgent care?
Do you have, whether it's in the US or Canada, you have specialists that want virtual visits, and can a patient, can they access them?
Yeah. So just to quickly answer your question, then I'll dive onto this slide. The answer is yes. And in Canada, we have about 20 different specialties on the system, and they're all using the same cloud-based record system, which is nice because we don't have fragmentation of care. It's almost like a virtual hospital in that way. And so there's, primary care, emergency med, mental health, and addictions medicine are the next two biggest specialties, but we have neurology, allergy, immunology, genetics, obs and gyn, ortho, everything you can think of is basically available in the system north of the border. In California, we've started with primary care, urgent care, pediatrics, mental health, and obs and gyn is the next big thing, which makes, and we've got addictions that's getting rolling as well.
Okay. And that's super helpful. So in Canada, are the patients able to self-refer to the specialist, like to the neurologist? Be like, hey, and then your platform like connects them to that?
No, so you have to get a referral from a primary care provider, except for addictions medicine, where patients can self-refer direct into that.
So you have the flow where an in-person or a virtual PCP is then referring to a virtual neurologist?
Correct. Yeah.
And so a lot of times the specialists are very test, procedure, and lab driven. So how much care are they able to deliver without having to do all that extra stuff that they normally do?
Well, that's a great question. It brings me to one of the bullets on my slide, which looks probably very out of place and is not meant to be political at all, but it just reminds me of a funny exchange between Obama and Romney. And there's this sort of thinking, and this is not at all targeting you, Eric, or your question. This is just my anecdote that I love to tell.
Sure.
Because of this idea of like, I just got so frustrated with everybody talking about commoditization of virtual care. And I was like, a doctor is not a coffee bean or a steel alloy. And we're not a hamburger, fast food shop of like a race to the bottom, or at least it shouldn't be. But we've seen what happens with that with certain corporate examples where it just produces terrible outcomes. So the idea was, well, if you can actually empower a physician to practice full scope medicine on the platform, then they're able to take care of those things. So like for a specialist, for example, as you said, we've got the ability on the system where docs can order labs, imaging. They can book in-person appointments if they like, because they're the independent physicians. They can actually bring a patient in. And in some cases, we've built the intake. Like I thought you were going to ask a different question initially, or say something, which is specialists are very picky about the kinds of patients they want to see also. In some cases, like subspecialty to that point. So we've built out a separate admin team that funnels the correct patients to that specialist practice, in some cases by geography as well.
Right.
And then they're able to order and then we have a back end team actually with PAs and nurses who will talk to patients and try to find, for example, like a sleep study center or a PFT center in that patient's geographic area to help them actually book it as well.
Okay. So there's the quote unquote care coordination piece for all those things that then have to be done obviously in person, and then the results just go back to the virtual neurologist in this example, and then they have a follow-up consultation with the virtual neurologist. Is that correct?
Correct. Exactly. Yep.
It'll be interesting, and you probably already very well this is that in America we have a super huge specialist access problem. People just cannot get in, and so there's obviously specialists that have access on their schedules, but they're just not geographically lined up where the patient need is. And so it would just be super helpful to have specialists who are, I'm facetiously saying twiddling their thumbs, but if you had specialists who actually had capacity to then see people who like literally, they're, in America, we're used to like, hey, 2 weeks, 4 weeks max, where we're getting, we're getting like, oh yeah, we can see you, February 26th of 26 to be able to get in the door.
Yeah. I think much of this looks the same on both sides. And what I have noticed from the US side of things is that there is an arbitrary firewall between insurance and doctors, and the complexity I mentioned earlier about figuring out how to start your own business. And so, yeah, there are doctors with availability in their schedules, and maybe they're interested in accepting patients. And I'll give you a California example. So let's say you want to take Medicaid in California. It doesn't work like that. So you've got to know that you have to get in network with Medi-Cal, which is California State Medicaid first. Mm-hmm. And that process can take anywhere from like 3 to 12 months, probably usually 6 to 9 months. through all of their bureaucracies and loop and whatever. And so you jump through all those hoops, you get Medi-Cal. Well, now you've got 80 managed care plans of Medicaid in California. And those managed care plans will each individually require that you talk to them and you convince them why you're appropriate to join their provider network. And most of those managed care plans will want you to prove that you have an office in their geographic region that they serve, even if you're going to do virtual care. And that's simply because that's how the system was designed and started and set up. And so you've got to know how to, and then if you get a enrollment, so you got to negotiate a contract with each of those managed care plans, and they have to agree to take you a network. And then when you negotiate the contract, then you have to go through credentialing with the plan. So you've got to go through all those other hoops. So by the time you start your practice to finally get your first payer enrollment, it might be 2 years before you can even see your first patient on your first plan. So, and then you got to figure out, well, okay, I'm a specialist. There's a 2-year wait list for, mental health, let's say. But then patients, like, I go back to when I started Rocket Doctor. I had no clue. I thought I'd make a post on my personal Facebook page and I'd get flooded with patients to the business. Had no idea about Google ads and online market and SEO and all brand and all this other stuff. And channel partnerships. And so most physicians will then, need to figure out, well, how do I actually get patients? And even once you get a contract with the plan's not going to advertise you to members. You got to figure out how to reach members at the plan. So it's just like, we've tried to figure out how to streamline all that, and we're not quite there yet, but we're getting closer as we push. I don't know if that helps with what you had in mind, or you may know more about this than I do. I admittedly don't know too much of your background.
No, that's super helpful. Thank you. I'll be quiet. I don't want to monopolize the conversation.
This has been great. We got a couple more questions. So Ikra, I know you joined about halfway, but feel free to ask your question and about rheumatology examples.
Yes.
And
hi, yeah. I'm Ikra. Hi, Will. So I'm actually credentialed in both Canada and the US, and I heard about Rocket Doctors from my friends and family, actually, because they were telling me about how, again, there's such a shortage of specialists on both sides of the border. And so I, for entirely personal reasons, because I am a rheumatologist, I was wondering if somebody like a rheumatologist were to, start practicing with you guys, or even gastroenterology, I think would run into the same problem. How do you manage the infusion side of things?
Yeah, so that's where it gets a little more specific, and there's 2 ways to kind of think about it. One is that we kind of produce the storefront, like a Shopify for the specialist. So doc will come in, let's say rheumatologist, I want to start an independent practice. We would create a landing page, intake page, looks and feels like the doctor's, preference for how they want to run their business. We would then put that out to the primary care providers that are on the platform, and they would then be aware of the specialist. And it takes time. Like, I think it's funny because, not funny, but, doctors expect things to move like really quick. They don't really understand how marketing works, that it takes, like, in some cases, a year to build brand awareness and to start drawing up the business. But it takes, usually we find, like, anywhere, again, from probably 3 months to a year for a doctor to start building a sufficient volume of referrals from the PCPs and the urgent care docs on the platform. But then, the team on the back end will filter based on the patient's geography. And so most specialists will have some in-person work that they're doing, and they can bring patients in when required for that. Or maybe they have colleagues that they work with, or maybe there's consults they can do where they're giving the patient a consultation, and maybe they can't do a procedure, but the patient needs one. They can refer them to a colleague. So, basically every specialty, I think there's things that you can still do in a virtual ecosystem, even if you're not. I think I started my residency in general surgery. I think back to the clinics we used to run and all the, consultations we do with patients where we wouldn't need to do procedures. We could look at imaging and give a recommendation and a kind of next step. So, yeah. And then of course, once you've built that page, physicians can put it out anywhere. And there's various e-referral systems and online platforms where folks can get themselves advertised in that way.
Yeah. So it sounds like what you're saying is for things that still need in-person care. So you mentioned like PFTs and sleep studies, and I guess you could think of infusion centers along the same line. It's really partnering up with colleagues or places that are able to offer those things in person, and then you do what you can virtually, and then sort of try to partner up with someone who can offer that side of things in person. Gotcha.
Yeah, exactly. And the alternative for most patients is either you've got to fly somewhere else or drive, which is not doable, or wait a year or two, basically.
Yeah, no, definitely. I think this is a really great initiative. And I think especially in Canada, I mean, I practice in the US, so I can speak to the US, but just, listening about like experiences of friends and family in the Toronto region, like seeing a rheumatologist sounds like a really painful process, and I think what you guys are trying to do here with Rocket Health, like kudos to you guys. I think it's a wonderful initiative.
Thanks. Rocket Doctor, though, by the way, for our name. But
Rocket Doctor, sorry.
no, you're good.
So, quick question about handoffs. Do you optimize like record transfer or summary of visits when downstream when people go outside of your system, or you kind of keep it as a traditional? They can get a faxed record or whatever.
Yeah, so the partner in the US that pulls the data so US has 21st Century Cares Act, every patient has a right to their data, EMR companies can't charge if you have a patient consent. We can pull data on anyone to give to the physician, to push data back. That partner has an API to Care Quality, so we're building an API to them currently so we can push back. As of now, yes, we're doing like an eFax system, but we also have the ability to email a patient a password protected PDF so that they can access their records in that way. And we have a patient portal so that you can see things there. On the Canadian side, there's no such legislation, but each of the provinces are kind of building their own provincial systems for digital integrations. Just a quick thought on the last note as well. And as we think about Canada versus the US and Rocket Doctor in particular, I always joke that it took a Canadian to see the problem with Medicaid in the US healthcare system. And quite frankly, it's the closest thing to our Canadian model. There's a federal mandate, and then it's devolved to the states to each build their own single payer government funded system, which basically is the same thing as the Canadian, Canada Health Act and provincial health insurance. So anyways, just an interesting side note.
And I think we have a couple more questions we will get to, or let's see. Yasaman, I don't know if I have your name correct. You had a question about doing multi-provider visits. And if you're in transit, and we can come back to it. And then Preston is asking about CDS support. Preston, do you want to ask your question?
Yeah, I just, you mentioned, taking care of the overhead and the annoying work for clinicians. I was wondering, are you also integrating or planning to integrate any sort of additional real-time or real-time support for helping the clinicians in the actual treatment planning and diagnosis work to make them more efficient and reduce the overhead of repetitive work of like, let me write a whole treatment plan by hand again. Let me type all the instructions again by hand.
Yeah, so we got acquired by a company called Treatment.com AI. They're a public company, and they basically have this global library of medicine and built onto LLMs, and we're building integrations with their tech and our system, both to intake patient data in advance, but also to provide some level of guidance to the physician. Actually, this goes back to the very beginning of the company, where I always wanted to have clinical decision support and predictive analytic tools where we could allow doctors to see what their peers are doing, to standardize care, and to provide options based on like treatment recommendations by, let's say, the American Association of Family Practice or USPSTF. And actually, Paulius and I are doing a little bit of work on some of that stuff at the moment to sort of see how we can build more of those options for docs. Currently, that stuff isn't there in the system, but I'm hoping that it'll be there before the end of the year.
Nice. And I know there are a couple more questions, but also people wanted to get to Medicaid policy stuff. So I know you have like one last slide on there, whether you just talk about it or pull up a slide, whatever works, because that's an interesting one.
Yeah, I can share. I added one extra slide this morning, actually, because the Times article just came out today with a couple of new updates. But Yeah. So my first bullet was this idea that north of the border, it's politics is politics. It's the same idea, and the media picks stuff up. And so, like, there's been a whole thing with the Canadian federal minister of health where it's like cracking down on virtual care because there's a misinformed perception that virtual care equals uninsured services and private pay healthcare, and we're going to quote unquote crack down on that. But that's actually not how healthcare works in Canada. It's devolved to the provinces to figure it out. And so the federal government actually basically has no authority other than to mandate provinces do things. And then the provinces have to do it later. And then it takes a long time and it has to be negotiated on a case. So that feels a lot like what's happening in the United States, where somebody says, well, there's going to be Medicaid cuts and there's Doge and the government has to be cut and spending has to be reduced and Medicaid is on the block. But then when you actually look at the tangible evidence of what has happened, so far, nothing has been cut, although we do anticipate something will be cut. And the question goes back to, okay, how are they planning to do it? And then it gets into politics where it's like, well, we don't want to lose the next election. We don't want to get destroyed too badly at the midterms, and we don't want to hamper the red states. And we want to be, so they've looked at a couple of different options. One of them is this Medicaid provider tax, which is this idea that basically states kind of upbill Medicaid and then charge the federal government to cover their costs for it. And it started out in New Hampshire, but now basically every state does it. And if they were to suddenly cut that, it would just be like a huge nightmare to actually mostly red states. And at a high level on point, 1, 2, 3, 4, 5, like second from the last there, or maybe the bottom line. Anyways, the wealthier coastal states often have the ability to take on debt. Versus some of the less wealthy states, often red states, have, and I'm not an expert in it, and some of you may be more expert than I am in this, but this is from what I've kind of learned over the last few years and studied myself, but that they would have to reflexively cut budgets to match federal funding cuts because they're not allowed to run a deficit at the state level. And so, and they have legislation on that. So in the end, the voters that voted this government into power would be the ones that would be most disadvantaged and lose access to Medicaid but wealthier, often blue coastal states would be able to just use state funds to offset Medicaid losses. So that's one of the reasons why it's not yet been done, trying to find sort of fancier ways of doing it. The other thing is looking at the Affordable Care Act, and that's been tried every which way to be cut over the years. Just as a quick highline, the ACA looks at 138% of the poverty line. And so looking at, could we target the ACA, and in California, that looks like covered California and other things as opposed to, full on Medicaid. Today, there was just an article that said they're still pushing for almost $1 trillion in savings over a decade for Medicaid. And these are the ways they're kind of creatively trying to handle things, sort of indirectly. So mandating work requirements, 80 hours of work a month for childless adults, checking paperwork. So you may have heard about the Medicaid enrollment that happened the last couple of years and de-rostered millions of people that were rostered under COVID, the unwinding, that kind of stuff. And then copays. So for people who are above the poverty line, so that would be the Obamacare expansion people who, and just think about if you were trying to survive on $15,000 a year. So 135% of the quote unquote poverty line is like, I think, what, 20K or something a year, 18K a year. So if you're a wealthy quote unquote Medicaid person at 135% of that poverty line, you're going to have to pay $35 every time you see the doctor. That's one of the ideas they're floating. That one could be very destructive because people can't necessarily afford $35. And then, this fourth bullet, and then undocumented. So California passed legislation to enroll 700,000 undocumented people into Medicaid. So that's an example of how they're trying to target the coastal Democratic states who often will take undocumented folks, and they would bring funding. I think it's down to 80% from 90% coverage, which is pretty substantial if you're a state that has, healthcare for undocumented people. So 2.3 million people are estimated to lose coverage out of the 80 million or so based on this. So it would still be very detrimental, but it's not going to be as severe, but they're still trying to get creative about ways to take healthcare away from people at the moment. That's my policy sort of thought process.
Perfect. I think that's great. If anyone has, there are definitely some policy folks here. If y'all have comments, questions, maybe one more comment right now, and then we might wrap up a little bit with a few minutes to spare to let other people hang out. And if no questions, then
Alias, I have a non-Medicaid question, if it's okay.
yeah, I think that's cool.
Bill,
Yeah.
Bill, this is awesome. Thanks for sharing your story. It sounds like one of your main customers is the independent physician. I'm curious how you go about letting them know about Rocket Doctor. How do you market to them? How do you encourage them to join? Sounds like it's a whole different world for them to step into, which sounds wonderful, but it obviously sounds like something very different than maybe what they're doing currently. And curious how you go about letting people know and market to them.
Yeah, to date, we've not done actually much of any marketing to physicians across the US. And the reason for that is we've got a sort of core group of a dozen or so. And we get like doctor, maybe one every couple of weeks that just organically hears about us and reaches out, and we onboard them onto the platform. But we have to carefully match supply and demand. And so all that stuff we just talked about, that's all work about pay enrollment, credentialing, et cetera. That's work we've been doing since basically January of 2023, getting the group in place structurally, foundationally, putting all the building blocks, winning contracts. And so we just launched our first managed care plan contract with 500,000 members in January. And we've got about a dozen other managed care plans we're in negotiations with to get in network with in California. And basically, and we're working now with the plan we're in network with to scale volume, which is why I kind of made that comment earlier. And they are helping us actually, which is nice, but we're building up the system. So we're kind of balancing supply demand at the moment, and we don't want to overshoot. That's one thing we've learned very clearly is you don't want to bring a doctor on and say, I can give you 8 hours a day of work with a full panel of patients, have them go through all this credentialing, and then you go, well, I got no patients for you. And then the doctor quits and everybody's unhappy. So we're just sort of being careful about it. And we'll probably start to build a wait list soon. And then as we start to generate more patient demand, we'll just start to bring more physicians onto the platform.
Nice. Well,
and on the Canada side, is it similar or a different story?
No, Canada, we're just like, we're chugging along. So more like any doctor in Canada can, so if you have friends in Canada, let them know. We can always take more docs on the Canadian side. And we have a whole in-depth patient funnel to grow that marketplace also.
And Mordechai, Bill's in our Slack, and so you guys can keep chatting. Same with Matt if we don't get to the question, but I'll stop the recording and just wanted to say a huge shout out to Bill for just taking the time. He's super busy doing stuff after the acquisition. And anyway, I appreciate you sharing what you've learned. And this is such a cool topic to learn about. So thank you. And thank you everyone for coming. This has been fantastic. We can keep the conversation going.